Hello, this is Professor Sajid. We will continue with our discussion on to the yesterday's genus that we started. And let's meet with a gentleman whose name is John Hunter, and he was a Scottish surgeon, remained from 1728 to 93. And he did a very strange self-experiment to prove some of his own theories. He is considered to be as a leading authority on the venereal diseases, the diseases which are transmitted from through sexual transmissions. And he believed that gonorrhea, which is caused by Neisseria gonorrhoeae, and another venereal disease, syphilis, which is caused by Treponema pallidum, they are the same diseases, and they're caused by the same pathogen. Now, he inoculated himself with the gonorrhea using a needle that was unknowingly contaminated with the syphilis, because he considered that syphilis and gonorrhea are the same thing. So he presented himself as an experimental individual and injected himself with a needle that was known to be contaminated with the syphilis. After that, he contacted both the diseases, that is the gonorrhea and the syphilis, and he said that the same underlying causes are the same. After about 51 years of this theory that the syphilis and the gonorrhea, they are the same disease, another scientist who was a French physician, his name was Philip, he proved that Neisseria or gonococcal infection and the syphilis, they are not the same thing. They are two different things. So that was the sad story. Some people say that he did not inoculate himself, but he used a third person, but it's a controversial theory. The objective of introducing this gentleman to you was that we should realize in the very beginning, for the rest of our life, that gonococcal infections are different and syphilis infections are different, although both belong to the same category of venereal diseases. Both are sexually transmissible diseases, but Neisseria is caused, the gonococcal infections, gonorrhea is caused by Neisseria gonorrhoeae, whereas syphilis is caused by another organism known as Treponema pallidum. Now, if you look at the presentation of this Neisseria gonorrhoeae, we all know that they are the paired organism. They have a kidney bean shaped and their concave surfaces they face together. And this is how the excellent picture that we can see, that the two organisms occurring in pairs facing together, and this is what we call the diplococcus organism. The gonococcal infections is caused by Neisseria gonorrhoeae, whereas the meningococcal infection that we discussed before, that is caused by the Neisseria meningitidis. Our today's topic is Neisseria gonorrhoeae. Now, if you look at the important properties of the Neisseria gonorrhoeae, it has almost the same properties that we already know, we discussed in case of Neisseria meningitidis. It's the gram-negative diplococci. It has a paired kidney-shaped configurations, and their concave surfaces they face together. So whenever you make a smear from the specimen, you can always have a look into the paired organism. These organisms, the Neisseria organism, they are very sensitive to dehydration and the cold temperature. That's why you see the sexual transmission, it favors their survival in the less cold environment and in the wet environment of the area, the genital tracts. Now, compared to that of Neisseria meningitidis, whose power of potential of pathogenesis was the capsule, the power of producing disease in case of Neisseria gonorrhoeae is not the capsule. It does not have a capsule. The capsule that we know we had in case of the Neisseria meningitidis, which was polysaccharide capsules, but this organism is not capsulated. It does not have capsule, but the power of potential of producing disease of this microorganism is the pillars, which is protein in nature. So compared to that of the main contributing virulent factors, that was capsule in case of Neisseria meningitidis, the main virulent contributing factor towards virulence is the Neisseria gonorrhoeae is the pills or the pilli. So the both organisms, they produce the exotoxins, and both they require the same media because they cannot go into the plastic fatty acids and other things. The growth of this organism, it is also inhibited by the toxic taste elements and the fatty acids present in the generally used biological medium that we normally use in the laboratory. This organism is oxidation positive, and it's a very unique characteristic with this. Almost we have all the same properties with reference to the morphology and the growth requirement that we have in case of Neisseria meningitidis. Both require different kind of medium, the chocolate agar, both are diplococci, and but there's one big difference. Meningitis having capsule. Neisseria, they don't have the capsule, but they have the pilli, and they should have that because of the gram-negative microorganism. Now, if you look at the pathogenesis and epidemiology, the Neisseria gonorrhoeae, it is sexually transmissible disease. The reservoirs are the humans. The human, you see, the organism is not normal flora and the vaginal tract in the male, but the disease is acquired through the sexual intercourse or sexually transmissible disease, what called as the venereal disease. Nowadays, the venereal disease term has been replaced by sexually transmissible disease, STDs. So the current name for the venereal disease that was used in the previous years is now has been replaced by the pelvic, the sexually transmissible disease. So these are the STDs. The human, they are the asymptomatic carriers and the principal reservoirs, as I told you. The pilli are the most important virulent factor. They constitute the most important virulent factors. If we have seen that non-pileated Neisseria gonorrhoeae, they are avirulent. If mutation has occurred in that an extent that the pilli are no more there, or a stage which does not have the pilli, it cannot produce the disease. So pilli stains are the virulent stain, whereas the non-pileated stains are the non-virulent stains. This means that pilli are the major virulent factors in case of Neisseria gonorrhoeae compared to that of Neisseria meningitidis, where the capsule was the main virulent factors. The cell wall virulence, factors are the lipopolysaccharides and our IgA protease. Now, the lipopolysaccharide is, again, you see in this case, it's again lipooligosaccharide because there's short chains compared to that of the rods in case of gram-negative rods. Primary, in fact, the mucosal surface of the urethra and the vagina. So the organism has the tendency to survive in low temperature area, in area where there is somewhat wetness, like the urethra and the vagina, because it cannot survive the hard, cold temperature. As I told you, we have very important virulence factors, the pilli and the outer membranes to some extent. Now, pilli, they're very important structures in promoting the attachment of this microorganism with the mucosal surfaces. Now, once it gets attached, it invades into the tissues and it infects the epithelial tissues. And you see, because the pilli, they does not only act as the attachment or adhesion factors, but they also contribute to some extent they act as an antiphagocytic factors also, as we see in case of capsulated microorganism. Now, IgA protease, they really cut the IgA antibodies on the mucosal surfaces, and this helps in the colonization of this microorganism in the mucosal surfaces. The organism has equipped itself with a weapon of IgA protease that cut the secretory IgA proteins so that it should make place to live in that area. The outer membrane proteins, which also used for the structural serotyping. Of course, we don't have much of many of the serotyping, and we don't have much of studied on that. But the O proteins, upper proteins, what is the best protein antigen variation, and there is adherence. So the outer membrane proteins, broadly speaking, along with that of the pilli, they contribute towards the virulence of these infections. Now, if we look into the categories of gonococcal infections, we have the genital gonorrhea in case of females, and we have the genitourinary gonorrhea in case of females. So both males and females, they are affected, and they are infected in the process of intercourse. Male would have the genital gonorrhea, the female would have the urogenital gonorrhea because of the close proximity of the through openings. Then the extragonococcal infections in other organs has also been reported with gonococcal infections. The children, they can also get the infection, what we call as the gonococcal infection in children, and they normally have the eyes infection, what we call as the ophthalmia neonatorium. It's newly born babies, when passing through the birth canal, they acquire the Neisseria gonorrhoeae and they get infection. So we have the gonococcal infection, genital infection in males, urogenital infections in case of females, extragonococcal infections in both of these males and females, and the neonatal ophthalmia neonatorium, what we call as the gonococcal infection in children. Now, the genital gonorrhea in male, large number of the individuals who are infected with the gonorrhea, they does not show any sign and symptom. They remain asymptomatic for some time, but then they lead to the acute urethritis, which is accompanied with severe dysuria, purulent yellowish discharge from the penile opening. And the disease can spread to the prostate and epididymis, leading to the prostatitis, epididymitis. And the infertility may be due to the scar formation of the spermatic cord. So this disease, whether it's in female or in male, it can lead to infertility in both the sexes. In male, because of the scar formation in the spermatic cord, and in female, you see there's a blockage of the fallopian tubes. So, genital gonorrhea in males is indicated with dysuria, purulent discharge, can spread to the prostate, epididymis, and can lead to scar formation, resulting into infertility. Now, the genital urinary gonorrhea in case of females, the bowel system, they are infected. The urinary intercourse, due to the proximity, as I told you, because the opening, both openings, they are very close. So during the intercourse process, there is a possibility that the contaminated, the infected individual place the organism in both of these areas. Now, this mucopurulent or bloody vaginal discharge, and there is dysuria. But the major complications of genitourinary gonorrhea due to the involvement of the high reproductive structures, the ascending infection in the uterus and in the fallopian tubes. So the infection can travel forward and spread to the menstruation, and it can lead to the self-angiitis or pelvic inflammatory diseases. So this was the passages of the genitourinary gonorrhea in case of females. But the complication of the pelvic inflammatory conditions, they are very common with regard to the infection of gonococcal organism. There is sterility because of the scar formation in the fallopian tubes. There may be ectopic pregnancy that has been reported because of the blockade of the fallopian tube. Now, there is abscess in the fallopian tube because of the disseminated gonococcal infection. There may be, you see, the abscess in the ovaries because of the spread of the infection. Now, there is perihepatitis, what we call as the fish-goose syndrome, and may follow after chlamydia infection. Now, chlamydia trachomatis, it is also a sexually transmissible disease. And sometimes they coexist, but most of the time, you see, I would say, most of the time, 2-3 sexually transmissible diseases, they exist together. So while treating the venereal diseases, we should also keep in mind other organisms that are responsible for the sexually transmissible diseases. And we'll have to treat those organisms simultaneously. And one more factor that we'll have to keep in mind, while treating the sexually transmissible diseases, we should always provide coverage to both the partners, and we try to trace out the epidemiology so that the other individuals, untested individuals, untreated individuals should not act as source of further infections. Now, this gonococcal infection is a notifiable infection. Notifiable means that wherever you see a patient suffering from this kind of infection, we will have to bring it into the notice of the higher authority, higher administrative health authority. so that the prevalence of this disease in the community can be prevented by taking the preventive measures. This is the second most important disease, notifiable disease in the United States, by the way. If you look at this, the reproductive tract of females, and we just have a look into the invasive gonococcal infections, this is what you call it, the normal fallopian tube on your left side, and on your right side, you see you have the gonococcal infection, and can see the ectopic tube pregnancies in case of this area. So the infection travel from the area, go to the uterus, then to the fallopian tubes, can block the fallopian tubes. There is scar formation, and if there is a pregnancy, it will remain in the fallopian tube, what we call as the ectopic pregnancy. Ectopic tubular pregnancy is a complication of the gonococcal infection in females. Now we have some of the extragenital gonococcal diseases, as I said, and both in men and women, these are the gonococcal bacteria, which is very rare. Organism, after entering into the bloodstream, it remains there and causes bacteria. So wherever the blood will go, the organism have the chances to settle down over there. And this is what leads to the disseminated gonococcal infections, very common. Even in the it can cause pericarditis, endocarditis, meningitis, septic arthritis, or pustules of the skin. So because of the dissemination of the organism, due to the presence of bacteria, we can have these kind of inflammatory reactions everywhere in the organs. The co-infection of Neisseria gonorrhoeae with syphilis, which is called like Treponema pallidum, and chlamydia trachomatis is very common. So we have three simultaneously preventing sexually transmissible diseases: the gonorrhea, which is caused by Neisseria gonorrhoeae; the syphilis, which is caused by Treponema pallidum; and we have the chlamydia trachomatis. Now, this is how the gonococcal infection will look like in children. This is what we call as the ophthalmia neonatal. This is keratitis, blindness can occur. See, this happens after 1 to 2 days of life, after birth. The babies, while passing through the birth canal, they can acquire this infection. I mean, this means that the Neisseria gonorrhoeae organism is present in the birth canal, and they can acquire this infection during the process of birth. The adult can also be infected in this case. Now, we can prevent these infections by the erythromycin ointment or by the silver nitrate drops. This is a very common complication of gonococcal infection. How can we diagnose the disease in the laboratory? You see, the diagnosis of urogenital infection, it depends upon gram staining and of course, the cultural discharge. We can also use the nuclear amplification test. In men, particularly the finding of gram-negative diplococci within the polymorph nuclear cell in the urethral discharge specimen is sufficient for the diagnosis. But in case of females, the use of gram stain alone, it is difficult to interpret. Therefore, the culture should be done. Gram stains on cervical specimens can give us the false positive result because of the presence of normal flora over there. And the specimen from the mucosal sites, such as the urethra, cervix, they're cultured onto the thyromarter medium. Now, thyromarter medium is nothing, it is just a chocolate medium, but it has 4 antimicrobial drugs incorporated in that. They are the vancomycin, colistin, trimethoprim, and nystatin. You see, the nystatin provides protection against the growth of the fungal infection. So in order to inhibit the growth of the normal flora, and as you know that the Candida albicans is a fungus that is frequently present in the vaginal tract. So in order to prevent the growth of the normal flora, both bacterial and fungal regions, the chocolate medium has been incorporated with these 4 antimicrobial drugs so that it should inhibit the growth of the normal flora, and only the pathogenic microorganism of gonococcal infection, they can grow onto this. So that is the significance of the thyromarter medium. We can also perform some of the sugar fermentation tests, like the oxidase and the maltase. The oxidase test is positive in case of Neisseria gonorrhoeae, whereas the maltose test is negative in case of Neisseria gonorrhoeae. It is positive in case of Neisseria meningitidis. Now, this is to just let you know that if you look at this slide, you can see the intracellular survivor of the Neisseria gonorrhoeae organism in the macrophages. You see the paired organism, the diplococci, the gonococci are the diplococci, the pneumococci are the diplococci. So we can see the diplococci microorganism. Now, differential diagnosis, as I said, it's very important to differentiate the gonococcal infection from chlamydia trachomatis, trichomonas vaginalis, gardnerella vaginalis. Trichomonas vaginalis is a protozoan. Chlamydia trachomatis and gardnerella vaginalis, these are the two microorganisms. We'll have to differentiate these microorganisms from the other diseases. Now, treatment in case of gonococcal infection, ceftriaxone is the drug of choice. If an individual is allergic to penicillin, we can use for the azithromycin, and we can go for the ciprofloxacin. The complicated cases like pelvic inflammatory conditions, diseases will have to hospitalize individuals so that it should be done in a proper way. Now, the resistance to gonococci is becoming increasing day by day. The penicillin producing Neisseria gonorrhoeae, they're very common in almost every country of the world. It is spread almost everywhere. We have almost 10% of the gonococcal organism which produce the penicillinase, and the penicillin is not effective against these microorganisms. Now, resistant ciprofloxacin is also becoming very important. So a time will come, maybe we'll have to go for the antimicrobial sensitivity testing for this microorganism. But currently, this ceftriaxone is working good. So we can use this drug for the treatment of these infections. The prevention, in case of adults, there is no vaccine available, so we cannot use that. The only way is that you will have to use the condom or use all other precautionary measures. And the neonates, the erythromycin, as I told you, or the sodium citrate or nitrate, so they can be used as a prevention to avoid the ophthalmia neonatal. That was all about the gonococcal infection. Now we have one, two more organisms, and I will take just not more than 5-7 minutes on that. Apart from the Neisseria gonorrhoeae and Neisseria meningitidis, which are diplococci and which are bean-shaped microorganisms, we have, but then gram-negative cocci, we have some other organism which is also very much relevant to the Neisseria microorganism. We have the MORAXELLA CATARRHALIS. This organism was previously known as the BRANHAMELLA CATARRHALIS, but it has been renamed now because of the sequencing of the DNA. This organism has homology very much close to the Neisseria family, so it has been put into the Neisseria family. It has the same family, but it's a different name. The Neisseria, the MORAXELLA CATARRHALIS, which was previously known as BRANHAMELLA CATARRHALIS, is also gram-negative, but it's a cocco-bacillary in nature. It's a cocco-bacillary. It's not the pure, you see, the cocci. It's a cocco-bacillary in nature. It's resembling the diplococcal morphology as we have in case of Neisseria. This organism is the normal flora of the upper respiratory tract in case of humans, and the transmission is via the droplets, the respiratory droplets, as we have seen in case of sorry. This organism, it can cause otitis media because of being present into the nasopharynx area. It can extend to the ears, to the sinuses, causing sinusitis. Can go down to the bronchitis. Can become a part of the blood. Bacteremia leading, and then septicemia leading to meningitis, bronchopneumonia, endocarditis, mostly in the elderly patient. The trimethoprim and sulfamethoxazole, which is a combination of two drugs, is freely available in the market with the name of Septron, and Bactrim is the drug of choice. And we have another species, MORAXELLA non-liquefaciens. It is a common cause of blepharitis, which is called the inflammation of the eyelid. This is very, no, the inflammation of the eyelid or the eyelid infection is very common with Staphylococcus aureus. This organism is the second most important cause of blepharitis in case of human beings. So the first major cause of blepharitis is the Staphylococcus aureus. It is followed by MORAXELLA non-leucofaciens, which is common. This is common. Now, another organism that we are left with is the Acetobacter, and the name of the organism is Acetobacter baumannii. This organism is a persisting microorganism. Means that if an individual is immunocompetent, his or her immunity is fully functional, this organism cannot cause a disease. Only immunocompromised individuals, either because of the steroid therapy, because of the anti-cancer therapy, because of the diseases, HIV, things like that, they are more prone to this infection. The organism is, again, you see the cocco-bacillary in nature, diplococcal morphology as we have in case of Neisseria. That's why we have decided to study it in the same manner. The habitat for this Acetobacter baumannii is the soil. It is present in the water, it is present in the seaways, and it colonizes on the skin or onto the upper respiratory tract because it's present in the environment. All those organisms which are present in the soil, they're always present in the environment. And all those environments which are present in the water and seaway, they're always present to see in the, we can always hear that. So this organism is oxidase negative, whereas the Neisseria gonorrhoeae was oxidase positive. It is not clinically considered as significant microorganism because it is not a common cause of infections of the respiratory tract or the skin of the individual. Most infections, they are hospital-associated infections, what we call nosocomial infections. And if an individual is placed onto the respiratory therapist, respiratory supportive equipment in the hospital, such as ventilators, they're more prone to these infections. So it's an ventilator-borne infections. Hospital infections, the infections which are acquired after the admission of the patient in the hospital, they are known as nosocomial infections. These are not infections that are carried from the home to the hospital. The individual, once admitted in the hospital, if he or she get the infections, this is what we call nosocomial infections. This means that the individual, if he or she get an infection at least 48 hours after admission in the hospital, that may be a nosocomial infection. But once the patient has been admitted from the home to the hospital, and very next morning or within the couple of hours, you see that he has the infection, it may not be a nosocomial infection. Acetobacter's nosocomial infections are very common if a patient is placed onto the ventilator. It can cause septicemia, meningitis, it can cause endocarditis, pneumonia. Name the disease, it is there just because of the inhalation of the organism. And then it enters because of bacteremia and septicemia leading to endocarditis and meningitis. Most, as I told you, they are associated with the ventilators and indwelling catheters also because the organism is present on the skin. The septicemia, meningitis, and UTI infection and frequent manifestation with this organism. This organism is remarkably resistant. And some of these strains has been known to be resistant to almost all the available antimicrobial drugs. So treating nosocomial infection with the Acetobacter baumannii is a very, very big challenge for the clinicians. The preventive is better than cure. We also always have you see the continuous screening of the hospital environment and the operation theater environment. We'll have to look into that whether the stain is present or not by continuous sampling from this area and culturing in the laboratory. Susceptible stains, they can respond to the venom, and there is no vaccine against that. So that was all about today's presentation. I hope you must have enjoyed our discussion and keep enjoying your journey of online learning. Thank you very much.